As you know, this is an educational series that is coming out of UCSF with the specific purpose of helping patients, family members, and caregivers better understand what to do if someone has a hereditary mutation that predisposes someone to have a risk for cancer. Reminding you, if you have a hereditary mutation, that doesn't mean you have cancer, you have a risk of cancer. Some mutation predispose you to prostate cancer, some to breast, some to colon. And we're trying to focus disease specifically and have a panel of experts helping us guide you through the process. How do you get tested? What is a meaningful mutation? Who needs screening? And how do we care for you? We have a dedicated clinic for this. We have a website where this webinar will be recorded and then posted, and we'll have, after Dr. Nguyen, who is going to introduce himself in just a minute, talks about prostate cancer, we'll take open questions. Great thanks to Dr. Letitia Taniwaki, who is in the background making this webinar possible. So, and Brian for support. So without further ado, I'd like to hand it over to Dr. Nguyen, who is a prostate cancer expert, works here at UCSF, and has been just an amazing collaborator. Dr. Nguyen.
Great, thank you, Pamela. And yes, it's been great. I first met Pamela through my mentor Peter Carroll, and we did a phase 1 trial on the PSMA surgery guided trial, and that was quite successful, and we're now moving on to the phase 2. So, but today I have the honor of discussing prostate cancer, hereditary prostate cancer. Let me share my screen here, and then we're gonna see if I can get this to work here. All right, so I'll be talking about
before you start, for the
yes.
audience, please type in your questions. I will get to the questions after Dr. Nguyen is done, but it'd be good if I can sort of like see your questions popping in.
Perfect. So I'll be talking about prostate cancer, a personalized management for patient with hereditary cancer mutations. And this PowerPoint is put together myself, Dr. Munster and Dr. Carroll. I'm currently a urologist at UCSF, and my focus is prostate cancer surgery. And so I'll be talking to you a brief overview of prostate cancer and the importance of understanding the genetic risk for prostate cancers, and it has implication how we treat the cancer, detect the cancer, and prevent or lower your risk. So what is prostate cancer? The simplest term, prostate cancer is when abnormal cell growth in the prostate gland and they start disrupting your normal body function. So a tumor growth from acquire mutations, and then it acquire this ability to proliferate. Uncontrolled proliferation is one of the hallmark, and that turn into a mass, and then it can obstruct the urine flow. For instance, you have a tumor, it can obstruct the flow of the semen, or sometimes it get into the bladder, obstruct the bladder, the urine flow from the bladder. If it goes beyond the prostate, it can get into the seminal vesicle and then invade into the rectum or adjacent organ. That would be stage 5. And that would spread to the lymph node and throughout the bone. Bone is the most common area for metastases. And then it can cause to other part of your body that can lead to multi-organ failure and death. So the incidence, the American Cancer Society estimate this year there will be about 300,000 new cases and 35,000 deaths from prostate cancer in the US. It is the second most commonly diagnosed cancer, except for skin cancer worldwide. 5th leading cause of cancer death in men worldwide, with an estimate of about 1.4 million new cases and 375,000 deaths in 2020. So who's at risk in general? Who's at risk? What are the risk factors for prostate cancer? Age is one of the risk factor. prostate cancer risk correlate with age. Prostate cancer is rarely seen in men younger than 40, and the incidence rises rapidly with each decade after that. And then ancestry is another risk factor. A Black individual has the highest incidence, 176 cases per 100,000 men, followed by white men who has 103 cases over in 1,000 men, and then followed by American Indian and Hispanic, and then Asian is the lowest incidence. And then family history and genetic are the two other risk factors. Now, family history, if you look at the relative risk for family history, if you have a brother who has prostate cancer diagnosed at any age, you're 3 times likely to get prostate cancer compared to men without a brother who has prostate cancer, or father diagnosed at any age, 2.3 times more. First degree relative at any age, 2.8 times more likely to have cancer. Or first degree relative that have a prostate cancer diagnosis under the age of 65 increase your risk. Second degree relative also increase. 2 or more affected first degree relative, up to 4 times the likelihood of develop prostate cancer. And then genetics. So this is going to be the focus of the talk today, is about genetic or germ-line mutation in prostate cancer. The landscape of genomic testing is rapidly evolving with the completion of the Human Genome Project in 2003. So I'll be focusing on risk prevention, prognosis, and treatment selection in these patients who have germ-line mutations, particularly focus on prostate cancer. Who's at risk? What does this mean? So while the majority of prostate cancer, 85%, just occur by chance, the estimate 5 to 15% of prostate cancer are hereditary or associated with no mutations. And the paper from Pitcher published in 2016, when they sequence about 650 men with metastatic prostate cancer, and they look at germ-line mutation and DNA repair, they find that 1 out of 10 men with metastatic prostate cancer has an inherited germ cell mutation. And these knowledge has implication for detection, surveillance, and also management. So it's important to understand this and test the individual at risk. So what are some of the known inherited genes? The one that's most well studied is the DNA repair genes, and this is only a tip of the iceberg. The genome-wide association study have identified nearly 200 more common germ-line risk variant that's associated with prostate cancer, but it's not well studied yet. They're not being tested yet or develop new tests yet for these genes. So what we have today is just the tip of the iceberg. In the paper in 2016, in this paper that I mentioned earlier, when they sequenced men who, regardless of family history, men who have metastatic prostate cancer, and they look at DNA repair genes. So the most common mutation is BRCA2 mutation, 44% of those men, of those 10%. And then the ATM gene, the CHEK2, BRCA1, these are the 4 most commonly found germline mutations in the DNA repair pathway. And then you have these other genes such as microsatellite, such as the Lynch syndrome genes, etc. These are a smaller number of patients. And so I'm going to focus a little bit more on the BRCA gene. BRCA1 and 2 genes are genes that produce this protein that helps repair damaged DNA. And DNA repair is a vital process for normal cell to function. And it is a process where it fixes error in the genetic code. So all of us are made from this genetic code, DNA, and then that get translate into RNA, and then this is the final product. Now, when a cell divide, the DNA replicate, and it needs these mechanism to fix error during that replications. So these genes normally prevent cells from growing out of control and become cancerous. So when these genes are harmful, these genes are mutated, they lose their function and then allow the cancer to develop. So BRCA gene mutations are, again, these are inherited changes in DNA sequence of the actual BRCA gene. BRCA1 is in the 17th chromosome, BRCA2 is in the 13th chromosome. And the associated with increased risk for prostate cancer, not only in men who has these mutations, BRCA1 or 2. And especially for BRCA2 gene mutation, it increase the lifetime risk of developing prostate cancer up to 20 to 40%, or even 60% in some people with other mutations. And they also increase the risk of having a more aggressive form of prostate cancer and also being diagnosed at a younger age. So who should undergo testing? These are 3 different guidelines: the NCCN guideline, the AUA SUO guideline, and the European guideline. So any man who has metastatic cancer should be tested for germline mutations. Unfavorable histology, such as introductive feature in their cancer, ancestry. The NCCN guideline suggests that Ashkenazi Jewish should be tested early for this. Family history is the big one. Brother or father, 2 male relatives had prostate cancer or diagnosed before the age of 60, or anyone that died from prostate cancer. And then multiple cancer on the same side of the family, such as a history, hereditary breast or ovarian cancer or Lynch syndrome. A personal history of high-risk prostate cancer, so cancer that is Gleason 8, 9, 10, or even Gleason 4+3, or even advanced stage 3A or higher, or cancer that is outside the prostate, localized but still out, outside the capsule, non-organ confined disease. So these are the guidelines, and these individuals should be tested for germ cell mutation. And why? Why do we test these? So certain germline mutations associated with increased risk of developing lethal prostate cancer, such as ATM mutations, BRCA1 or 2 increase up to 20% risk, check mutation, OXB13 up to 60%, MLH1, MSH2, 6. So these are increased risk of having prostate cancer. And also these germline mutations also increase risk of breast, ovarian cancers, pancreatic, melanoma, colorectal, in these individuals. So the next one is, how do we perform germline testing? And there's the commercial tests out there. The one that I use most is the Invitae one, but there's the GeneDx and the Ambry Genetics, the NeoGenomics. These are different commercially available tests, and these are the number of genes that's being tested, 14 most common genes. In my practice, where I just often refer these patients to a genetic counselor, and they'll take over from that, and they'll order the appropriate tests that's available. And what is the time to start screening? So these are the summary of the current practice in different guidelines. So for the AUA and the American Cancer Society, they want, they recommend screening at age of 40. And for the European Urology Association, NCCN guideline that suggests recommended screen at age 45. So what are the implications for early detection? Why is it important? So if you have a mutations, you are at higher risk for develop cancer that can lead to a tailored cancer screening program. Potentially we can detect the cancer earlier. So in our practice at UCSF, men who have genetic risk for BRCA1, 2, ATM are checked. We start screening at age 40 with an annual PSA and a rectal exam. Now, the rectal exam is not a very sensitive test, so small tumor inside the prostate, and you may not be able to detect that with the rectal exam. We use more advanced imaging, so we use an MRI or ultrasound. Now, the MRI for these individuals, most often the insurance will not pay for it. So, the MRIs cost $3,000, but we also have a comparable exam is the ultrasound, and we have this the micro ultrasound, and it's quite sensitive, and sometimes it even perform better than the MRI. And this to get an ultrasound, it just costs $300 compared to this $3,000 MRI. So we have a tool with which are more cost effective to screen. So we use imaging is in our practice here. We use yearly imaging either with MRI or ultrasound or sometimes both, and then biomarker. So there's a variety of biomarker out there. The one that is the one I use is the Exosome DX, where it's a simple urine collection, and you can mail it to the home of the patient. They can do at the comfort of the home and mail it back to the company. We get the result back, and the result will let us know what is the risk of the probability of having prostate cancer. These are tests geared towards detecting high-grade cancer, not the indolent cancer. So I like these biomarkers as well. Now, what are the indication for biopsy? So any abnormal DRE, digital rectal exam, or PSA above 3, or an abnormal on imaging, we see something suspicious on ultrasound or MRI, that would be an indication, or an abnormal biomarker test. Also an indication for biopsy. There's a few approaches where I do biopsy, one through the perineum, which is less chance of infection. The other one is through the rectum, and the infection risk is low for probably less than 1% of the time we have case of sepsis. If we go through perineum rupture, that's almost 0% of sepsis. So and the procedure can be done in the clinic. It takes us about 15-20 minutes to do the procedure, so it's not that long. And it is a sensitive part of the body, so a lot of patients, they don't want to biopsy unless they have to. So we often get these biomarker test imaging to see their risk. But if they have elevated risk, then we'll go ahead and do that biopsy. Now, what is the implication of treatment? If you have a mutation, then it actually can inform treatment option. Some genetic mutation respond better to targeted drugs and specific treatment. For instance, I'm going to give you two examples of two recent patients I saw in the clinic. A 42-year-old man with Gleason 6 cancer who has Lynch syndrome. And we sent out a decipher test. These are tests these are more somatic genomic tests from the tumor. And his decipher test, there's 3 available tests on the market: decipher, cholesterol, oncotype. And then we use the decipher test in this case, and that came back low genomic risk. So, he hasn't started a family yet, so he elected active surveillance. So for him, it would be a tail because of known Lynch syndrome mutations. His surveillance is different from his counterpart who did not have the mutation. So it would be more frequent imaging, more frequent PSA, and surveillance biopsy. So you can see how we tailor these surveillance protocol towards these individual with known mutation. So it's important to test to know these things as well. So the other example is a 45-year-old man who has Gleason 6 cancer with BRCA2 mutation. Now his genomic risk is intermediate. So but his biopsies to show Gleason 6 cancer. And at the time, he's already had a family, and he told me, he want to see, he has 2 young daughters and want to see them grow up. So he said, I just want my prostate out. So I took out his prostate 4 years ago, and now he's disease-free. On the pathology, is actually Gleason 7. So there's Gleason 7 in there that was not detected by the needle biopsy. As you know, the needle biopsy can underestimate because these biopsies are very small, and if you harbor a small amount of Gleason 7, the biopsy can miss it. So that's why we rely on these genomic risks as well. So they can, these individual can elect for surgeries, radiation, or active surveillance based on the discussion with their physician and their background. So is there a role for risk-reducing surgery in these individual with low-risk prostate cancer? Now, this is a study from European Urology back in 2019, looking at the cumulative incident of upgrading after biopsy in individual with BRCA 1 or 2 mutation or ATM mutation. So if you look up here in the upper panel, so patient who had a biopsy, initial diagnosis with Gleason 6, they had higher risk of finding Gleason 7 if they elected for surgery or a subsequent confirmatory biopsy compared to individual without this mutation. So you can see the risk of reclassification is higher. 6 out of 11 men who are carrier for BRCA2 mutation versus 283 men out of 1,200 men in non-carrier. So 2.7 times more likely to have upgrading if you start out with a Gleason 6 cancer, or if you start with Gleason 7 cancer, 2.7 times higher to have found a Gleason 8 cancer during surgery or subsequent biopsy. So that's the one of the evidence showing that early treatment may be an acceptable solution for these men. Now, is active surveillance acceptable in men with BRCA2 mutation? What about active surveillance? Do they have to have surgery? So germline mutations is actually uncommon in low-risk individual, 1.4 to 4%. And those who treated with prostate cancer, surgery, radiation, a germline BRCA2 mutation is actually an independent predictor for metastases and prostate cancer specific survival. Surveillance is now a safer approach because of advanced imaging and our method of biopsy. So we have more accurate biopsy now with MRI-guided biopsy. We have better imaging, PSMA PET scan. So our surveillance strategy is actually safer now. And so you don't have to have surgery, basically. If you can have active surveillance if you have a BRCA mutation and delay surgery safely. And so there's still more study to be done to understand whether to treat or continue with active surveillance in these men. Now, when patient who has metastatic disease, so that's for localized disease. Now we move on to metastatic disease. So men with metastatic disease, currently the main treatment is androgen deprivation therapy or androgen signaling inhibition. But if you have a mutation in BRCA 1 or 2 or any of the DNA repair genes or mismatch repair, you actually have more option. So Keytruda been recently approved for men who has a mismatch repair genes, and also a PARP inhibitor is also approved. So actually, if you have metastatic disease, one of those, 1 out of 10 men with metastatic disease may have these mutations that have more therapy available to them. So the way PARP inhibitor works is that if you look at DNA damages, so DNA replicate, and if there's damage to the DNA, the cell has the ability to repair it. The BRCA gene, as I talk about, it encodes for a protein that helps the cell repair the DNA. So if the BRCA gene is deleted or mutated, they have a backup, the PARP protein, to help repair that DNA. But if you block the PARP protein and the BRCA mutation in men with BRCA mutations, and then that allowed the cell to unable to repair itself, and then that leads to cell death. So that's the concept behind the DNA damage pathway in the new therapy. So let's move on to family implication. So if a patient has the genetic changes, their children or sibling might also have the same changes. So identifying it may lead to a cascade testing in family member, allow them to understand or find cancer before they spread. So that's another important thing to get genetic testing. It may help your family as well. And then last is the implication on risk management. So if you have a gene mutations and you don't have any cancer yet, but it may help, you may take steps to actually lower your risk of getting cancer, such as avoid cigarette smoking, eat a healthy diet, maintain a healthy weight. So if you test and you found out you have one of these mutations, you may modify your lifestyle and decrease your risk of having of developing these cancer. So in summary, about 10% of all prostate cancer are linked to an inherited gene changes. If you have a BRCA2 mutation, most studies show that there's around 40% chance of developing prostate cancer over your lifetime. Prostate cancer screening is recommended to start at the age of 40 to 45 with annual PSA and rectal exam in these men. Also use advanced imaging that is available to us. MRI, ultrasound, biomarker that may improve the accuracy of detecting this cancer early. PSA and rectal exam is not the perfect test. So now we have newer technology, we should utilize it. The genetic testing is now becoming a standard of care for patients with aggressive cancer. So men who develop aggressive prostate cancer should be tested and not have implication on the family on detecting other cancer, such as pancreatic cancer, colon cancer, and also help tailor their treatment as well. And in those men who carry these BRCA2 mutations or BRCA1 and who have low risks of prostate cancer, it's still unclear whether we should treat early or go on active surveillance more. So the decision has to be well informed and discussed with the patients and their provider. So there's still a lot of study on that. So that is my slide, a portion of the talk, and then I think our next part is going to be question and answer, right?
Mm. Thank you so much for this very informative lecture. I learned a lot, and it's always really good to hear you, Dr. Nguyen, because it's so amazing how rapidly this field is moving along and how many new options we have. And I think this is in part why we created this clinic, so that someone who gets diagnosed with a BRCA mutation some 8 or 9 years ago gets the possibilities or the option to see us every 6 months. We do all the screening, we schedule the screening, but it's really also important to be participating in research and have an opportunity to learn more about the advances. And before we launch into the questions, following the Q&A, and there's a lot of good questions for you, Hao. I also like to call out a couple of people who have been very helpful. Danielle Sipes, who is making a flyer. Thank you, Danielle, for the hard work. And I think the flyer is really creating attention. I really like to thank our communications team, Karen and Aaron, to put this webinar on our website, and our IT person who helps this a lot. And then I see on the call are our amazing genetic counselors. A lot of times when we have questions about, who should get tested, what's the quickest way to get tested, what does the test mean, we have now the opportunity to always bring patient back to see the genetic counselors. So with this, question is like, should you take a prostate out prophylactically if someone has a BRCA mutation or high-risk mutation? Is there any prophylactic prostatectomy or removal of the prostate, what we do for women in breast cancer?
Yeah, that's a great question. Currently, there's no evidence showing these early, prophylactic surgery for prostate similar to breast cancer. We don't have evidence to show if that helps reduce their risk of developing cancer later on, or death from prostate cancer. I think the important thing is to detect early and tailor the treatment accordingly, because removing the prostate is a life-changing experience. Is similar for women. Removing the breast is a life-changing thing, but for prostate, especially for men who found out at the young age, and losing the prostate, that means losing the natural fertility, sexual dysfunction, urinary incontinence. These are some of the side effects that is life-changing. And I don't think there's a study or evidence showing that the risk is worth.
Do you think in breast cancer, the risk for breast cancers are very high, and often we don't have good screening methods. We don't have a blood test for breast cancer. Do you feel you can say with reasonable confidence that a good screening program for prostate cancer makes it so that the prostatectomy is really not needed? Is that
Yes, absolutely. Yes. So, maybe 10 years ago, I maybe different answer, but now we have these biomarker that's quite accurate. These exosome tests that I use, the 4K test, there's the prostate health, there's many different biomarker that we use to detect, and they're quite accurate, up to 90%, 91% in accuracy. And now we have imaging. We have MRI, PET scan, and so to miss aggressive cancer with all this technology is low, I think, if we do screening carefully and tailor the screening differently for these individuals with germline mutations.
And follow up on this question, of course, most of us who are not expert in prostate cancer, we hear about PSA testing as a simple blood test, but then there's PSA and there's total and free, there's 4K. Can you explain it in a little bit easier way of what that means actually?
Yeah, so a PSA is a prostate specific antigen, is a protein produced from prostate, and it can be bound to other protein, or not bound to other proteins. So that's total PSA is when they calculate the free and bound PSA. And then there's free PSA, which is not bound. And if you look at the data, men who have low free PSA, they tend to have higher incidence of prostate cancer. That doesn't mean high-grade cancer or low-grade cancer, just overall prostate cancer. So that's what it means. And we now, we use that as the initial test, but not the test that would trigger a biopsy. I would use more of the biomarkers, more accurate in detecting high-grade cancer than free and total, and that would trigger a biopsy. The biopsy is not completely harmless. Is uncomfortable for some patient. There's small risk of infections and stuff. So
And before we go back in the more like high risk patients, so if someone has a high PSA or is told they have a high PSA, what does high mean? And you know, what is a number associated with high? How do you look what a high PSA means? And does this always mean it's cancer?
Yeah, so PSA basically the high can be a relative number. Some individual, let's say a PSA of 3, that based on the test, most would say above 4 would be considered high PSA. But an individual with a PSA of 3 and the prostate gland is only 12 grams.
That
So that
means small,
3,
right?
yeah, so that 3 is actually not normal for them. That would be a high PSA for that individual. So what I use is PSA density. We see these individual and we do an ultrasound to get the volume, and then PSA divided by volume. It's 0.1. If you have a PSA, a prostate gland that for 40-year-old men, prostate is around 18 grams or something. And the PSA should be under 40 years, also based on age also. The PSA in these individuals should be under 1, but if it's high, if PSA is 2 or something, that would consider high for that. But in a 60-year-old with a PSA of 2, that's considered low, 60, 70-year-old. So it's based on age, based on the volume. So high or low, you can have just a general idea of a number based on the test. Above 3 would be considered, but you have to individualize and based on age and volume as well. So it's hard to say high or low.
So what you're saying is like whenever a man gets a PSA test, discuss it with your doctor and determine what the PSA number means for you as an individual.
Yes, absolutely. Yes. Yeah.
Okay. Thank you for that. So I'm going to go through some of the questions in the chat. It's like Dr. Nguyen, we tell patients if you have BRCA related prostate cancer is more aggressive. What does more aggressive mean? What does aggressive refer to?
Yes. So aggressive, basically when prostate cancer is diagnosed, we can, the way we tell a patient whether cancer is aggressive or not is based on how the cell look under the microscope, the cellular changes under the microscope. And this is determined by the pathologist. So they give it a scoring system called the Gleason score. So it can be 3, 4, or 5. So 3 would be low aggressive. 4 or 5 would be aggressive or high aggressive. So that's just a grading system and how aggressive and aggressive cancer, these are lethal cancer. Gleason 6 cancer, they're not considered lethal cancer, but Gleason 7 or higher, those men can die from it if it's left untreated. So that's the aggressive cancer that is lethal, and that's based on how the cell look under the microscope. Now there's another way now we assess risk is genomic risk. So if you dive deeper into the cell and look at the DNA, and that's called the genomic risk. And these tests that is commercially available, they give us a genomic risk as well, low aggressive, intermediate, or high aggressive. So there's genomic risk, and there's also pathological or cellular risk.
And just to clarify this a little bit, when we as a medical community talk about the lethal cancer, that refers to if the tumor were left alone and no one does anything about it, right? Doesn't
Right.
mean if you have a Gleason 4+5, like doesn't mean you're gonna die from it, but you need treatment otherwise.
Right. Because prostate cancer, most of the time, you have a long natural history. So if left untreated, aggressive cancer left untreated, you're not going to die in the next 5 years or 10 years, but the cancer may spread locally and affect your body functions, such as emptying your bladder well, or blocking the invading your rectum, cause rectal bleeding, or can spread to the bone. So it can cause all these things and inhibit your body function normally. You're not going to die yet, but in 10 years, you may have metastasis if you don't treat it.
Thank you for that. So a question that actually comes up quite a bit. So someone inherits their BRCA mutation from their mother, and no one on the mother's side has prostate cancer. But the father who doesn't have a hereditary mutation, doesn't have a BRCA2 mutation, has prostate cancer. Does this magnify the risk?
I think so, yeah. So if you have a family member of who does not have the BRCA mutation but has prostate cancer or aggressive prostate cancer, that increases your risk. But if you have a BRCA mutation on top of that, it can increase your risk even more. Yeah.
Yeah, we actually see this also for breast cancer. Often we have families that have a BRCA mutation on one side and breast cancer on the other, and we clearly think that this is magnifying the risk. So, and it is also true, we have a lot of prostate cancer that may be high risk, and we don't have a good understanding on where the prostate cancer is coming from.
Right. There's a lot of genes that has not been characterized yet. So these 20 genes that we looked at on these genetic tests, look at 20 genes, but there's 200 genes that we have not we identified but not studied well, but there's probably more. So I think this field's gonna develop further. We'll probably have more commercial tests that look at other genes as well, besides the DNA repair genes. That is the mainstay of these current genetic tests.
And can you talk a little bit about if someone has a parent with the prostate cancer and a BRCA mutation, and they don't have the mutation, are they not at risk for prostate cancer? Are they a lower risk? Or like, let's say,
So
a man who has BRCA2 mutation and prostate cancer, and the son is tested and is negative.
yeah, good question. So if they don't have the BRCA mutation, the risk is lower. But if they have but they have family of the father or brother who has prostate cancer, whether the BRCA associated or not, they're still 2 times high likely to get prostate cancer. Yeah, there's familiar reason for it, but we have not identified these other genes yet.
And then would you recommend such an individual to start screening at 50 or at 40? How would you handle that?
Yeah, so based on the current guideline, if you have family history, we would start screening at 45, age 40 or 45, actually. Yeah.
Okay, so someone with the BRCA mutation, we start at 40, family history of 45, and general population of 50?
Yes, yeah.
Okay.
Yeah. The individual with BRCA mutations, besides the PSA, besides the regular DIE, we may do more in screening for these using biomarkers or MRI, other source that may improve the accuracy of detecting these cancer earlier than just the regular PSA and DIE.
So an important question that, of course, comes up a lot in women with breast cancer or a risk for breast cancer is, can I take estrogen? What about testosterone? Is testosterone safe for BRCA mutation carriers? Do we have data? Do we know?
No, yeah, we don't have data yet on that. So that's a good question that I think would be a great topic for men who has low testosterone and had BRCA mutations. In general population, low testosterone, we give testosterone supplement, we don't see increased risk. So, but for BRCA mutation, we don't know. That's is an answer at the time.
Dr. Nguyen, I think it'd be an amazing research study that we can do in collaboration to see how safe it is to give testosterone in men with
Right.
BRCA right? So I think
Yeah,
this
absolutely.
the
Absolutely.
important question that I'm afraid when you come to clinic, we don't have a good answer for you because we just simply don't know the answer.
Mm-hmm.
So, okay. Is PSA good enough to monitor as a test alone for someone at high risk?
You know, I think PSA is a good starting point, but it can miss cancer. So it's not the perfect marker. In our clinic, we use imaging and biomarker in addition to PSA. So I think PSA alone is not enough for this high risk individual. Um, yeah.
Thank you. Of course, we know a lot about the risks for prostate cancer and BRCA1, BRCA2, ATM. What about the Lynch mutations such as MSH3, MSH2,
Mhm.
MLH1? What's the risk for prostate cancer? Do we have more solid data now? Or we still...
Yeah, we do. We have some data. There's a 30% increased risk if you have one of these Lynch syndrome associated mutations, and yeah, so they do have, you know, for BRCA's 20-40%. For these other Lynch, it's 30%. It is increase your risk if you have one of those mutations.
Mhm. And if
Yeah,
you...
the for prostate cancer, I think, you know, I think for breast, you do prophylactic surgery, right? And do you have data showing that these benefit in the long term for these men for this woman who elected prophylactic mastectomy, or now with the better early detection or colorectal cancer, that kind of, you know, do you,
So I think for breast cancer, the recommendation for risk-reducing mastectomies are very strong for BRCA1, BRCA2, PALB2, much less clear on an ATM and check, and even there, like there's no consistent recommendations for prophylactic or risk-reducing mastectomies. And you know, it just depends what the risks are for the individual, how it's compounded by a family
Mhm.
history. We make individual recommendations. Our screening programs work fairly well, but like with many imaging, we don't have 100% foolproofness. Some of the newer blood tests are coming and they look very promising, but still maybe not as good. It is a very emerging field, and I think the one thing we need to know is like any imaging is early detection, is not prevention. I think what's really
Mhm.
needed, and what as probably many of you know, my family has a BRCA mutation. We are very keen to find new ways of early interception and prevention that doesn't include losing your organs.
Mhm.
So, and I think this is why we have this clinic. We are really grateful for all of our donors. We have a lot of involved families who are involved with the participation in research, with funding, with support. And so I think it's been one of my most exciting areas of work where we can really make a difference, I hope. And I think your contribution in the prostate field is very important. So going back to our question, so like if you have a BRCA-related prostate cancer and you take the prostate out, do a prostatectomy, how do you follow those patients, and do you follow them differently? And like
Yeah,
what?
so BRCA mutation is actually an independent predictor, even for patient who's treated, you know, predictor for metastasis and death later on. So we do follow them after surgery, and PSA is actually an excellent biomarker to detect any early sign of relapse. So once the prostate is out, you should not make any PSA. It should be zero. So if any signs like the PSA is like 0.01, for instance, which is very low, then that would be a sign of relapse. And we can detect them with simple PSA test every 3 months for these individual, or every 3 or 6 months would be more stringent follow for these men, and it's a simple PSA test. So it's not costly to do it. So that's the good thing about surgery, is that, PSA is quite an excellent biomarker after that to detect relapse.
Please clarify for us, is like we talk about BRCA mutation causing aggressive prostate cancer. This still means that a man can be cured, right? If their prostate, all the cancer is gone, there's still a very high chance of being cured and the cancer never coming back.
Absolutely, yes. Detect early and we treat appropriately. Yes, definitely. Intent is to cure the cancer if detect early and localized disease. Yeah.
What is the lifetime risk for prostate cancer if you have BRCA1, not BRCA2 mutation?
Yeah, the would be one out of I think is BRCA1 is is actually leads to diagnose at an earlier age, but not as aggressive as BRCA2 mutations. And the risk is similar, 40% lifetime risk increase. But usually those individuals have earlier onset with BRCA1.
Okay, thank you. There's a question on this, and that is been around as a question for a while. Is BRCA1 and BRCA2 more common in Ashkenazi Jewish family, or is this common? Do we see this in other people?
I don't know for sure. I think probably more common in Ashkenazi Jews, but you see it in African American, Asian. So is yeah, it doesn't discriminate in terms of ancestry so much.
So I think to follow up on this, as we see more patient, I think remember how this field started, folks, is like until 2013, when the Supreme Court struck down the ability to patent the gene testing was actually extremely expensive and was really paid for if you had a very young family member under 50 with breast cancer, ovarian cancer, and if you had at least one first-degree relative. I remember at the time I got tested, my testing was actually not really approved because I didn't meet the criteria. So because family history of breast cancer and a mutation compound each other, many Jewish families were found to have young breast cancer and young mutations. Now, I think as we do more broader testing, we probably will find that as Dr. Nguyen says, mutations don't discriminate. They don't necessarily have a racial preference. The risk of the tumors may be different in different ethnic and racial background. But I think if you're not Jewish, it does not mean you cannot have a BRCA mutation. I will say, though, if you do 23andMe testing, and if you're not Jewish, your BRCA2 mutation will not show up on a 23andMe. So I think an 23andMe makes the disclaimer that the results are only reliable if you're Jewish. But I'm struggling with this concept a little bit. This is like, can you imagine doing a pregnancy test that only turns positive if you're Jewish? I don't think that would be quite acceptable in other areas, right?
Right.
So, but I think that this disclaimer is clearly there. I think the reason why some tests are not as clear is because the BRCA gene has multiple amino acids, and many of them can be faulty. Some faulty gene mutations have a meaning that cause cancer, and others are not. And often when you get a test that says you have a BRCA mutation, and a variant of unknown significance, or VUS. We actually don't know whether this causes cancer or not. I think the key is really to find out if you have a mutation that is this meaningful. Many of our mutations are clearly defined as pathogenic, so I mean they're associated with risk, others are not.
Right.
Does Medicare cover testing for BRCA testing or other mutation testing?
Yes. So if you fall into that risk group, according to the guideline, they will cover it. So any personal history of breast, ovarian, family history of breast, ovarian cancer, or a patient who have now high risk of prostate cancer, we send them to get the genetic testing, and it's all covered now. So it's not a problem anymore to get. I know in 10 years ago, it is very expensive and it's hard to get these, but now is part of the standard practice now. And I think it's underutilized. So if you're seeing a doctor and you have a high-grade cancer, you should ask your doctor to refer you to a genetic counselor and get tested. And it's going to help you or help your family. If you have one of these mutations, you want to know about it. And your son or daughter may want to know about it and change their lifestyle and not reduce the incidence of getting breast or prostate cancer in the future. Yeah, so it's important to get tested. And
yeah, thank you for that, Dr. Nguyen, because I think it's important to know about your risk for cancer and being really screened differently. And as we established, if you have a BRCA1 or 2 and other mutation, your screening for prostate cancer may start at 40, not at 50. Would there be a 10-year difference where you could detect a cancer early?
exactly.
Other question, if you already have a confirmed BRCA2 diagnosis, is it recommended to get tested for other genes or have your tumor tested for other genes?
Yeah, so if you have you carry a germline mutation of BRCA2 and you have a cancer, like let's say for prostate cancer, yes, so they could do testing, genetic testing on that cancer and help you tailor their treatment based on that result. They may screen you for other cancer, pancreatic cancer, or colorectal cancer, or other cancer as well. So not only prostate cancer. So it's going to be very informative for the clinician as well in helping you making decisions.
Drilling down on the biomarkers on 4K and ultrasound tests for BRCA positive men or BRCA2 positive men, is this done on an annual basis, even in the absence of a diagnosed cancer?
Yes, so I do for patient on IC, I do yearly. I do the rectal exam, but I don't think it's sensitive enough. So I do yearly ultrasounds, quite a simple test. A yearly MRI would be hard to get the insurance to pay for it. So I do a simple ultrasound. We have this micro ultrasound. The regular ultrasound is 9 megahertz, but this is a 29. So we can see really detail. These are ultrasound. I can actually see the needle track from the biopsy from a year ago. Actually, let's do that. So we have these in our clinic that at pretty much no cost to the patient, and I do them on a yearly basis. And if the patient requests me to do every 6 months, I can do them. It's quite simple. It takes me 10 minutes to do. And yeah, so I'm a big fan of finding more information about the patients. And so we have a lot of and these biomarker tests. Now, it's a simple urine collection can be done at home. So how easy is that? It's quite easy to do it. And if it's most of the time it's covered on a yearly basis, the insurance you get paid, insurance pay for it on a yearly basis. So yeah, for these individuals, I'd rather screen carefully than removing the prostate prophylactically, you know. So that's the idea.
A clarification from one of our attendees. You said BRCA1, there was a 40% increase. Do you mean a lifetime risk of 40%?
Yes, yes.
Okay, thank you. If you had a prostatectomy and you said like after that you shouldn't make any PSA, if you have a prostatectomy and the PSA increases, does this always mean a relapse, even if the scans are clean?
Yeah, so relapse can be two form. One is, can you see it on imaging or not? If you cannot see it on imaging, would be a called biochemical relapse. So you can detect PSA, or there's this prostate cancer, the prostate cell in your body that makes this PSA. And the way we tell whether it's cancer or benign cell that makes it, sometimes we follow PSA, and the PSA kind of stable, flat line, then there's more likely benign cells near the urethra or something that's making this PSA, not necessarily cancer. Cancer cell, they tend to have PSA that keep rising. Yeah, so those are biochemical recurrent. So the definition of biochemical recurrent is if you have a PSA of 0.2 after surgery, or rising PSA after surgery, or if you elect for radiation, it would be rising PSA after your lowest level, or above 2 from the lowest level. Yeah, yeah.
And then is there treatment for biochemical failure?
Yeah, so if you cannot see the actual location of the cancer, let's say you have a surgery and the PSA is rising and you get the scan, can't see anything. So we would assume that is in the prostate bed or in the pelvis, and we would counsel the patient they can elect to have adjuvant or salvage radiation to the pelvis, the general area around in the prostate bed, to radiate those. So if some cases we would allow the PSA to get to 0.2 or a little bit higher and get imaging to see if we can identify the location, and then tailor the treatment accordingly to the site of recurrence. And we also do imaging as well. If there's sometimes we would do an ultrasound, transrectal ultrasound, to look at the prostate bed. We find any evidence of visible recurrent in that area, and biopsy it, and then tailor the treatment.
Do you routinely screen with the rectal ultrasounds?
Yeah, so I do. It's a simple, and we at UCSF, I train with Kazuto Shinohara, who's the, world famous sonographer. So we do a really good job at the ultrasound, and for elevated PSA or men who is at risk, typically I use an ultrasound instead of a digital rectal exam, in addition, as part of the screening. So we do a baseline ultrasound and a DIE and PSA.
Okay, one interesting question that it may be difficult to answer is like, does someone with BRCA2 related metastatic prostate cancer who's treated with a PARP inhibitor, does such an individual have a better survival than metastatic non-germline prostate cancer?
I don't know the question to that. Maybe the medical oncologist may have an idea. I think, yeah, I don't know if the trial have looked at that, where they compare,
I can answer this a little bit. I mean, that's a complicated question because survival depends on many factors. And often patients come to my clinic and ask me like, did I pick a good cancer? I think, and I don't think you get to pick a cancer. I think you don't get to choose what cancer you have, but you get to choose what treatment you have. And I think some treatments are better tolerated and more effective, and others are not. And I have to say, even after 30 years of being an oncologist, we don't know who's going to respond. We just don't know who's going to respond. And so I think important part is if you have metastatic prostate cancer, stay in close contact with your doctors, participate in clinical trials, and maintain a healthy lifestyle. I think even living with metastatic cancer is really important to
Yeah.
watch your diet, have exercise, and and while we're talking about exercise and diet, how do we know what obesity does to prostate cancer?
Yeah, so there is some data showing, men with high, you know, fat content in the belly, or they do have a higher risk of prostate cancer. And the data is still controversial on that. Some study didn't show any link. Some show a good association between body mass index and prostate cancer. So the data but there is some association, I think, at increased risk. So I do favor patient who has a mutation do maintain a healthy weight, to reduce their risk, not only of prostate cancer, but other cancer as well, associated with these gene mutations. Yeah, healthy. I think, if you have one of these mutations, DNA repair mutations, and you are smoking cigarette, you should stop, right? As a simple intervention, not reduce your risk quite greatly, and a healthy diet, whole food, kind of.
And thank you for this because having a healthy lifestyle, maintaining a good weight, and exercise just makes you age easier, and probably in a more healthy way. And even if obesity doesn't, even if it weren't to impact prostate cancer, right? The negative effects of being obese on the heart will make treatment for prostate cancer actually more challenging.
Right. Absolutely. Yes.
It's like
Yes.
you
Yeah.
take,
So it also limits your choice of treatment as well. So for patient who are obese, if they decide to have surgery, would be a harder recovery for them. That kind of thing. Yeah. So, or if you have heart disease associated with obesity, or that would be a harder recovery for them. Sometimes they may not even be a candidate for surgery, even if they wanted to, if they have these. Um, yeah.
So do you know of any data that suggests that there's a PARP inhibitor for prophylaxis in or early interception for prostate cancer?
Yeah, good question. We don't have data on that yet. I think that would be a good research question. Yeah, that would be good research. A lot of unknowns still in this field.
So I can make a little bit of a comment on this. We are currently working in one of our sponsor philanthropy-funded trials where we're actually trying to create an implant that goes into the prostate that delivers a PARP inhibitor directly into the prostate, doesn't go anywhere, with the hope that we can treat the prostate, but not the rest of the body, because the side effects of a PARP inhibitors are not completely negligible. So hopefully in the next 3 or 4 years, we can bring this into a clinical trial. And I think it'd be quite exciting to do that.
Yeah, that would be quite exciting. And if it works, there's a lot of other exciting thing that we can do with it. Currently the for prostate cancer, there's uh, uh, a tremendous interest in focal therapy, organ sparing approach. So we would treat just the affected part of the prostate that has cancer in it and we would spare the rest of the organ. That would preserve the sexual function, urinary function, these vital function that is life-changing if it's affected or interrupted. So, but the issue with focal therapy is a high risk of recurrent, and so focal therapy now we don't offer to men who has BRCA mutation. If you have a BRCA mutation, where even though the tumor is focal, it's just one part of prostate. I don't offer these because I worry that, it may not work well, but we don't have data yet to show, but I don't think it's work well. But if you have something like this with a PARP inhibitor, so that would be an excellent project. I think that's with tremendous opportunity for men who have these cancer and want to preserve organ and just treat part of it effectively, with different modalities, yeah. So that's exciting. I'm glad you're
So,
doing that work. I think that's
so
great.
hopefully we can keep you posted and may start these clinical trials soon. So,
Perfect.
let's come to another question that everyone, of course, worries about. What about side effects of a prostatectomy? Is like, are the side effects getting better? Are the side effects dependent on the skills of the surgeon, the anatomy of the men? What matters?
Yeah, so the side effects, it depends on all though. Those are all the surgeons, the anatomy, the overall health of the patients. So many factors that affect the outcome and recovery in terms of sexual function and urinary function. So uh, for sexual function, I think if you start out with a good baseline uh, sexual function, then you are more likely to recover better than your counterpart who has a lower sexual function to start out with, regardless of surgeon or regardless of prostate size and stuff. So there's independent predictors. Then there's other factor that we cannot control for, or we have not studied yet. Yeah, so when we remove prostate, the main side effect that's gonna impact men is the sexual function. Erections is the major thing. So and it takes a few years for men to recover from that after surgery, and sometimes they don't recover to 100%, and it relies on Viagra's or Cialis, that kind of thing.
And what
So
about incontinence? Is that a big problem too, or is this just
incontinence is not a big problem. Incontinent, most men has temporary incontinence. In most of the cases, resolved by 6, 8 months after surgery. Only 3%, I think, in the national average is incontinent that don't improve, and we need to fix it. And we can fix it with a sling procedure and artificial sphincter. But so incontinence is not a big worry for me when I counsel men who elected for prostatectomy. Main thing I counsel them is their sexual function.
Great. Is there a link between benign prostate hyperplasia and prostate cancer?
No, there's no link between those two. Uh,
That
yeah,
it's just both common?
yeah. Well, benign hyperplasia, most men have, at their age, they get very common. Um, but there's no association between that
Okay.
and prostate cancer.
Okay, then of course a question everyone always wants to know, is there any remedies that prevent prostate cancer? Any vitamins, herbs, extracts, green tea, anything that has been shown? And lots of things have been studied. Has anything been shown to be promising?
Not that I know in a controlled trial setting. A lot of it is anecdotal. A lot of it is non-control, non-randomized, and is a lot of bias study. So there's no if your patient has anything I can do to decrease your risk of having prostate cancer. I think it's the main thing again is if lifestyle changes, not rely on a vitamin or a supplement, but I would say, healthy diet, exercise. Those are the two main things. Avoid cigarette smoking, avoid all these carcinogen. Uh, so those I think more impactful than rely on a vitamin that has no real data to support it.
So, and doubling down on a question we probably answered before, but may still require a bit more nuances. If I have a BRCA2 mutation, and we typically the screening starts at 40, but the person has a brother who was diagnosed at 42, does this still start at 40, or should we go to 32?
32, very rare cases, I wouldn't, 32, I have not seen, so I wouldn't go 32 because for cancer to develop, it takes years to get there. So at 32, I don't think we would find cancer if you try to screen for that young age. Yeah, men rarely have prostate cancer below 40. So
Okay. A lot of people want to know now, can they make an appointment with you?
yes, my office is open. Yes, absolutely. We have a great practice, 7 oncologists. You see any of us. Yeah, so it's a great group here at UCSF, and we're quite fortunate to yeah, I'm quite fortunate to be at UCSF and have a program like the one that you're heading for hereditary cancer. I think it's a very important program. Remember, 10% of prostate cancer. 1 out of 10 men who have metastatic has a germ cell mutation. So,
And I think I really want to leave you with this clear impression. We don't see men with prostate cancer only. We really want to prevent prostate cancer and do early diagnosis. So if you have a hereditary mutation, we really want to see you early. We want to see you early to get you tested, screened, and really also, if you have any symptoms or anything, that you have a phone number to call. I noticed from my breast cancer patients, one of the biggest problem is I find alarm, who do I call? And for you all, it's us. Letitia, are you ready to put up the website with our numbers, okay. We'll have Dr. Taniwaki share our resources. If you want to take a screenshot of this, it's like
that's great.
you have a clinic number for our hereditary clinic number. Email us, call us. We really feel very strongly that people with hereditary cancer mutations need to have a home. We are here to help you test your children. We are here to help you get screened, or simply for questions. And if you have been unfortunate and diagnosed with a cancer, we'll get you treated. I find our team amazing. We have nurse practitioners, we have experts, we really have an amazing team, and I again would really thank everybody who has been participating. How your answers have been incredibly helpful. I'm pretty sure everyone is walking away with knowing a lot more, knowing where to ask questions. And just have to say, seeing more breast cancer than I see prostate cancer, I'm really, really proud of all the men for having all these questions.
Right.
Very, very good questions. And I hope this was helpful. And with this, I think I'd like to end this, and we're going to post this webinar on our website, right? So, and I think, Dr. Are you willing to share the slides if someone is interested?
Yes, absolutely. Yes, I'll send it to Letitia, and then yeah, absolutely. But yeah, you have a great audience here. Great question, very sophisticated questions, very well-informed patients. So it's a pleasure for me to be here, and actually an honor to talk about these important aspects of prostate cancer.
Hey, everybody, thank you so much, and have a good rest of the evening. Take care.
Take care.